The history of Belize malaria fight has come a long way.
If you look at as far back as maybe the 70s, 80s and 90s, you were looking at peak transmission times for malaria.
For example, I could recall times when I was in Orange Walk. It was very tedious. We would go out into the field, like from 6 in the morning and visiting houses from village to village. And we would come back like at 10 at night and still haven't visited all the people we needed to treat for that day. It was so prevalent in that time.
At the time, the program was more vertical and it was more of a malaria program.
We had our own budget, we had our own staff. We would manage a program from central level. That in itself gave the advantages of being able to maximize the effectiveness and the efficiency of the human resources, whereby you would ensure that they are working just on malaria.
Decentralization happened early 2000s, and what that entailed was giving authority to the various regional management teams that were put in place.
At that time, we faced some challenges in the sense that decentralizing the staff, then that means to say that supervision and the administration would fall under the regional management team, which we had some challenges there as to the skills of the management. What we did immediately is strengthen the skills of the new staff and those staff that we knew needed to improve their skills. So we had some training, very specific and continuous training. We ensured that all districts had the standard operating procedures, training manuals, operational manuals. That was key. And we would ensure that the surveillance would still be done as how it should be done, that the diagnosis and the treatment would still remain timely. At the headquarters, we continued providing that support, that technical support, that advice. We ensured the resources were there at the regional level for them to continue executing the strategies for malaria.
From my years of working in the program, malaria evolved from 1,000 plus cases early 2000 to 0 cases at present.
As the cases started reducing, we started working with more confidence in terms of this is actually achievable in terms of our goal of elimination. Over recent years, you've had the introduction of new tools locally. Insecticide-treated bed nets have been more affordable. So we introduced those, I would say maybe around 2009, 2010. And then we introduced a rapid diagnostic tests, which initially was quite expensive and now it's more affordable in the region. So there was a reorientation of the health services towards moving from malaria control program. That started somewhere, I would say maybe around 2013, 2014. As you move towards elimination and you want to do things like risk stratification, micro-planning and things like that, these are things that you need to bring your people up to standard, and that's where the reorientation process takes place. So we developed the first strategic plan for malaria elimination in 2018. At the ministry level, we developed the strategic and operational plans. At the district level, they take the national operational plans and devise their own specific operational plans. And the key partners at their level that they're working with is multiple partners.
We've trained doctors, nurses, administrators, PCAs, every aspect, every level of care, so that we all remember malaria and we remember to test for it.